Hi, my name is Padma Chinduru. I am doing a presentation on patient-centered diabetic care. And the objectives of this PowerPoint are just to kind of go through the definition of diabetes, talk a little bit about the disease burden, talk about treatment goals, and introduce a mnemonic that may help in terms of keeping track of all the parameters that are required for monitoring diabetics. A brief overview of some medications and also some telephone triage questions that may come up when dealing with a diabetic patient who's sick. So, diabetes is basically when your body has too much sugar, whether it is because it's not making its own insulin, as in type 1s, or because your body cannot use the insulin that it's making, as in type 2s. There are also a couple of more rare causes of diabetes called mature onset diabetes of the young and autoimmune diabetes. We're mostly going to focus on the type 2 diabetics in this presentation. The reason we worry about uncontrolled sugars is because it can double your risk of heart attack and stroke. Also, it can cause poor circulation in your small blood vessels, causing eye disease called retinopathy that can lead to blindness, and kidney disease called nephropathy that can lead to kidney failure, eventually dialysis, possibly needing a transplant. It can also cause damage to your nerves, causing neuropathy, which can manifest as numbness, tingling, pain of the extremities in a stocking glove distribution. The reason high sugars do this is because it makes the blood vessels difficult to relax. It damages the lining, causes plaque formation, and once plaque form, they can rupture, form clots. That's essentially causing a heart attack if that happens in your blood vessels that supply the heart. This is a map showing the worldwide prevalence of diabetes. As you can see, only about half of the diabetes in the world is actually diagnosed. In North America, it's about a little over 10%, and it's comparable to what we see here at our clinic and also at Hyannis. The screening guidelines for diabetes are having a blood pressure greater than 135/80, BMI greater than 25 plus, another cardiovascular risk factor, or having impaired fasting glucose, or having a first degree relative with diabetes, being a member of a high risk ethnic group, having low happy cholesterol or HDL, high triglycerides, physical inactivity, history of gestational diabetes, or having a macrosomic baby, defined as an infant weighing more than 9 pounds. If no other risk factors, we should still start at 45 and do it every 3 years. We also screen all pregnant women. So despite the fact that there's no universal screening recommendation, this encompasses a majority of our patients. So in order to diagnose someone of diabetes, we need 2 data points, whether it be 2 A1Cs or 1 A1C and 1 fasting glucose. So the A1C has to be more than 6.5, or the fasting glucose has to be more than 126, or a random glucose has to be greater than 200. Those are the things we look for. Sometimes patients present with symptoms of diabetes. They may say they're urinating a lot, or have yeast infections in their mouth, or vaginal infections, vaginal yeast infections, erectile dysfunction, wounds, sores that are not getting better, neuropathy symptoms, feeling thirsty all the time, losing weight. So once diabetes is diagnosed, there is a lot we can do in terms of decreasing the end organ damages by controlling sugars, and in some cases we can actually help get rid of diabetes, like in bariatric surgery and things like that, where they help you lose all the extra weight. So I wanted to go through a mnemonic, A, B, C, D, E, F, G's, for diabetes. The A stands for A1C. A1C is a number that corresponds to an estimated average glucose and it reflects your sugar over the last 2 to 3 months. It does not reflect any daily fluctuations. Our goal is that it be less than 7 to decrease risk of microvascular and macrovascular disease. So that corresponds to about what, like 150 glucose, average glucose. So the blood pressure goals, per the 2013 ADA guidelines, is that it be less than 140 over 80. Now, there are newer guidelines by other associations that are put out earlier this year that are a little different. We'll just kind of focus on this number for today. So home blood pressure monitoring is really important and should be encouraged in those with uncontrolled blood pressure, because it gives us more data points that we can adjust the blood pressure medications, on. So when you're doing a home blood pressure, some things are really important. It's important that you sit in a chair with a back with your feet planted flat on the ground, have your arm resting on a table. The upper arm automatic blood pressure machines are much more accurate than the wrist ones, so I discourage the use of the wrist blood pressure machines. And it's important to kind of get multiple data points, so 15 blood pressures over the course of 1 week prior to the provider visit, and changing up the times, maybe some in the morning, some in the afternoon, some at night, and encouraging the patients to kind of bring a list. Um, it helps, the monitoring helps get patients involved in their own care, similar to glucose monitoring that we'll talk about later. The C stands for cholesterol. There's different kinds of cholesterol. The cholesterol guidelines are also changing, but we'll just go through the most recent ADA guidelines. The ADA guidelines ask that the LDL be less than 100, and that's really the big one. The newer blood pressure, or I'm sorry, the newer cholesterol guidelines, they don't have a target. It's more based on sort of the risk status of the patient. You either pick a moderate intensity statin or a high intensity statin depending upon the initial patient's risk. So we're not actually treating the goal based on the newer guidelines. We just choose the potency of the statin based on their risk status. The D in the mnemonic stands for dental. As we all know, sugar and bacteria are bad together. They cause acid tooth decay. So very important that our patients get regular dental visits every 6 months. The other D stands for diet. Anytime anyone's newly diagnosed of diabetes, it's important that they see the nutritionist at least once to go through the basics of a diabetic diet. I like to teach patients about the plate method. It's very visual, so encouraging people to 50% of whatever they eat really should be fruits and vegetables. A quarter of what they eat should be a lean protein, and the other quarter should be a carbohydrate. And using a smaller plate for breakfast and a whole plate for lunch and dinner. Also encouraging low-fat dairy. This is the Vietnamese version and the Latin version. All right, next step is eye exam. As we talked about before, diabetics are at an increased risk of retinopathy, so it's important that they get annual eye exams to be screened for this. Also important are foot exams. Foot exam includes a visual exam, checking for pulses, doing the monofilament test to check for neuropathy. This should be done at least annually, but maybe more often. And once patients start having difficulty with sort of cleaning their own feet or development of calluses or having neuropathy, they should really be seeing a podiatrist. G stands for glucose monitoring. It's important that we set up our patients for a one-time ClinPharm visit once they're on oral hypoglycemic, so anything more than metformin, so they learn to check their sugars if and when they're having symptoms of hypoglycemia. Lastly, it's important to also screen for urine microalbumin. This should be done annually. Microalbumin is something your kidneys excrete before they start excreting protein. So if you do a urine analysis and they're having protein in their urine, you don't have to do microalbumin. It's already sort of past that. Microalbumin is the sort of the earlier state before people start having frank proteinuria. So things we can do to help our patients better, capturing them while they're at the clinic visit, whether it be for a sore throat or a cough, doing the pre-visit planning with visit planning reports, and using that information to figure out what they're due for and target those measures. And care coordinators to review the drives reports and reach out to the patients that are due for labs or eye exams or visits. So hopefully the next time we see a diabetic, we can use this mnemonic to our advantage to figure out what they need. Okay, so how often do we do this stuff? A1C, technically every 6 months. I said every 5 months just because if you shoot for 6 months, it becomes 7 months. So if we try to do it a little less than 6 months, I think we can, meet the every 6 month goal. That's if they're well controlled. If their A1C is less than 7, which is the average glucose, less than 150. Now, if they're not well controlled and we're adjusting their medications, we really should be doing it more often, every 2 to 3 months. The blood pressure should be checked every visit. They should be seen every month to sort of check their blood pressure and adjust the medications if they're not at goal. The cholesterol at the very least should be done every year. Once again, we want to kind of shoot for a little less than that so we meet the goal of every year, so every 10 to 12 months. And then more often if we're trying to get the LDL down. This is also, it doesn't quite make sense with the newer recommendations where it's you're treating based on risk and you're not really treating to goal. I know it's a little confusing, but because we're getting different recommendations from different organizations. Lastly, a well-controlled diabetic should be seeing their provider every 5 to 6 months. If they're not well-controlled, they should be seeing them every 2 to 3 months. So, does an A1C have to be fasting? The answer is no, because it reflects the average sugar over the last 2 to 3 months. It has no bearing whether you're fasting that day or not. Does your cholesterol have to be fasting? No and yes. This is a tricky question. So there's about a 10% variation of the LDL if you're not fasting. So if you think it's hard for the patient to come in, may as well do it. Or you can also consider doing a direct LDL. Fasting cholesterol is ideal, but it's only the LDL that we look at. It only varies by about 10%, even if the patient is not fasting. The triglycerides, on the other hand, vary a lot. So it depends upon what you're looking for. So let's talk a little bit about medications. First and foremost, metformin. It's very old, but it's really great medication. It promotes weight loss. It allows your liver to better metabolize the sugar. It doesn't really have hypoglycemia or risk of hypoglycemia. It may cause some diarrhea or loose stools, so it's important that we take it with food. Expected A1C decrease is 1 to 2%. In reality, I've noticed a bigger change because often once we start metformin, we're also encouraging dietary changes. So after metformin, everything else is considered hypoglycemic. They bring down your sugars, they increase your risk of low sugar episodes too. Sulfonylureas is a big class. These include glipizide, glyburide, glimepiride, amorel. These work best on the postprandial sugars, can cause hypoglycemia. Glipizide or glucotrol is sort of the best one in this class. It seems to cause the least hypoglycemia. once we get into the hypoglycemics, we should really be setting them up with a one-time clinical pharmacy visit to teach them how to use a glucometer, etc. That way, if they ever have any signs or symptoms of low sugars like dizziness, lightheadedness, palpitations, they can check their sugar and confirm that that is what is causing the symptoms. The next class is TZDs. So this is Actos. The sister drug Avandia has been taken off market due to some increased cardiac events. There's some concern that it may increase bladder cancer risk. This also can cause hypoglycemia. This is newer, as I guess it's not new anymore. It's been out for a few years now. DPP-4 inhibitors. These include Januvia, Tradjenta, Onglyza. These are generally used as additional therapy, but can also be used as monotherapy if patients can't tolerate the stuff that we presented prior. So if coupled with another oral hypoglycemic like sulfonylurea, it can cause more hypoglycemia. This can increase your risk of pancreatitis. So if someone gets started on this medication and they start having some epigastric pain, traveling to the back, and nausea and things like that, that is a concern. And the A1C reduction is less than 1%. The next class is GLP-1 agonist. These are shots, Byetta, Victoza. The Byetta is twice daily, Victoza is once daily. These can promote a little bit of weight loss. They can have a fair amount of GI side effects and also some risk of pancreatitis. Last but not least, insulin. So there's two kinds of long-acting insulin. We primarily use Glargine or Lantus here, so we'll just focus on that. There are two short-acting insulins, Humalog and Novolog. They're equivalent for all intents and purposes. All insulin can cause hypoglycemia and, unfortunately, weight gain. So sometimes we use some of the pills we talked about before to, kind of delay the initiation of insulin, because insulin, once you're on insulin, it makes it harder to lose weight, unfortunately. So Lantus and the short-acting insulins have really made diabetes care much simpler. Lantus or Glargine is supposed to emulate sort of your basal insulin levels, as seen in the picture at the very top. And then you do the bolus dosings with the Humalog or Novolog with food to mimic the glucose rise that happens after you take food. So this is, like you eat breakfast and a little bit later the sugar rises, same with the lunch, same with the dinner, and that sort of mimics the Humalog peak if taken with meals. So the Humalog and the Novolog peak or onset, the onset of them is within 15 minutes. So it's important that they be taken with food, or else they can cause hypoglycemia if you delay food intake after taking them. These are the general sites that are used for insulin administration, but really the ones around the abdomen are the best. It's important to rotate the sites around the abdomen so they don't cause any scarring. We generally start Lantus at 10 units at night, and then we ask the patient to increase it by 1 unit a night until the fasting sugars in the morning are consistently below 130. The goals for glucoses are the following. So the fasting sugars should be less than 130. We just talked about how we increase the Lantus by 1 unit every day until the fastings are consistently below 130. And then the 2-hour postprandials should be below 180, and you adjust the Novolog and the Humalog until that happens. For gestational diabetics, they have more stringent guidelines. So do I have to eat before Lantus? Nope, because this is supposed to emulate the basal insulin, so there's no peak, so you don't have to eat before taking this. Do I have to eat before taking Humalog or Novolog? Yes, that is correct, and it's very important. So I often tell patients to have a plate of food in front of them, administer their fast-acting insulin, and then immediately start eating. Um, Patients can often experience hypoglycemia if they start preparation of the food after taking the short-acting insulin. What if people have problems with dexterity or vision? Insurance will cover for pens for these reasons, and people who can't see the numbers can listen to the clicks. How long are the pens good once they're opened? 28 days is a good rule of thumb to remember. Some last longer, but everything at least lasts 28 days. So once they're open, you can leave it at sort of on the bedside, on the table for 28 days. The ones that are not open need to be in the refrigerator. What happens to metformin when a patient gets a contrast study? The patient should be instructed to hold it for 48 hours. Now, you don't always have to check a BMP and creatinine and all this stuff. It really depends upon if they have any chronic renal failure. If they don't, often you just need to hold it for 48 hours. It doesn't really require any other additional checking of creatinine. Are medications stopped when a patient is sick? No need to stop the metformin generally. You can continue the Lantus as well. Usually, when patients are ill, their sugars are higher, so we don't really want to stop anything. We should be monitoring sugars every 3 to 4 hours. Often, they need more short acting insulin in between, and they should try to continue to eat every 3 to 4 hours as usual. Depending upon their sugars, they may need to stop the fast acting, but not generally. Whatever the case, they should come in to be evaluated to see what the underlying infection is. Hydration is really key for hyperosmolar hyperglycemic non-ketotic syndrome, which is the high sugar syndrome that happens in type 2 diabetics. So water, diet soda, if you're not keeping any solids down. If your sugars are high, then stick with calorie-free drinks like water and diet soda and things like that. If you're not eating much, then try to get some sugar with the liquids like apple juice, Gatorade, popsicles. Try to get at least 1 glass of water in every hour. That helps reduce the sugar levels too. And they sometimes will need to go to the ER if they can't keep fluids down, vomiting every couple of hours, having DKA symptoms in type 1 diabetics, pain, nausea, trouble breathing, fruity breath, dry mouth, confusion. And for the type 2 diabetics, similar stuff. Their sugars are much higher, usually over 600. How to treat hypoglycemia. It's important not to over treat it, then you can cause high sugars. So 15 grams of carbohydrates is what's recommended, and then you wait 15 minutes to recheck the sugar. So examples of 15 grams of carbs include 4 ounces of juice or regular soda, 4 teaspoons of sugar, 1 tablespoon of honey, 4 grams, 4 glucose tablets, sorry, 4 glucose tablets, which is 16 grams. And then try to avoid things that contain fat because fat takes longer to metabolize.